Hello all. Just a couple things to go over this week. Firstly, this is a very long presentation. It comes out to 120 slides, so I might end up breaking this up into a couple different videos. We'll see how this goes. Past that, the exams are going to be graded at the end of this week. There were a few people had extensions, so I'm just letting them work through that before I go and sit down and do a grade them all session to go and get on them. I'll also be putting some feedback in those, just go and help guide you guys along a little bit. We have an additional study resource that we have not had before, I believe. At the bottom of the lecture page, I'm going to be including a interactive website region that can go and help elaborate on some of the concepts that we work with. Eventually, I will be going back and making those for our prior modules, but for now, I'm going to just be putting them on the future ones because of the limits of time and, trying to be realistic about that. Now, with that, I think that we can go and get into our endochronologically. We'll get started talking about the endocrine system, okay? All righty, so here we are. Let's go from the beginning. So right here, going into chapter 10 with the endocrine system, there's some supportive reading this week. We have our supportive web chunk at the bottom of our page. We have our study guide. We have many, many resources. But again, if you guys need any help or if there's something that you're getting frustrated with, never hesitate to call me. This type of course only works with constant communication. Never hesitate to ask about anything. Alrighty, so the endocrine system, we're going to go and start by talking about the functions and mechanisms of hormones, the hypothalamus and the pituitary gland, the thyroid gland, the parathyroid gland, the adrenal gland, and the pancreas. From there, we're going to be moving on to the thymus gland, the pineal gland, and local acting chemical messengers or intercellular hormonal communication, which is pretty interesting. Now, the main function of hormones in the body are to coordinate body systems and maintain homeostasis. So we use our nervous systems to send electrical messages between cells. Hormones are the way that we send chemical messages between cells. So the endocrine system works in tandem with the nervous system to send messages. However, because we are sending things chemically, they're having to diffuse through different fluids. They're having to be pumped by your blood vessels and your lymphic vessels and all that stuff. This communication is going to be significantly slower than in the nervous system. So your endocrine glands are going to contain secretory cells, and they're going to release their product, i.e. hormones, into extracellular fluid. Hormones then diffuse into the bloodstream, and they are our main chemical messenger. They are going to be the way that we send a chemical message from one cell to another. Exocrine glands are going to go and secrete their products into ducts. Now, ducts lead to either the interior of cavities, the spaces within organs, or outside of the body. So you have oil ducts in your skin to keep your skin tissue hydrated, but you also have salivary ducts to go and allow saliva to pull into your mouth. So here you can go and see some exocrine glands, like this oil gland that helps lubricate hair to go and help it pass out through the pore and also moisturize the skin. Here we have an endocrine gland, however. The difference between the exocrine gland, it's emitting a chemical to the outside of the body. The endocrine gland is emitting a chemical towards the inside of the body. This is going to a contact surface. This is not. The interior of your organs also would count as a contact surface, like the lining of your digestive tract and things like that, because they're in contact with stuff from the outside, the interior of your lungs, things like that. So the major endocrine glands are the pituitary gland, the thyroid gland, the parathyroid glands, the adrenal glands, and the pineal glands. Organs with some endocrine tissue include the hypothalamus, the thymus or thymus, the pancreas, the ovaries, the testes, the heart, the placenta, the stomach, the small intestine, and the kidneys. So all of these have some capacity to emit hormones to internal structures, either structures within within the organ itself or structures in adjacent organs. Here's a diagram talking about the pituitary glands, the pineal glands, parathyroid glands. These are all the major adrenal, hormonal endocrine glands of the body, and all structures that are going to be emitting hormones in large levels. And this is going to go and list the different types of hormones, as well as the function of those hormones throughout the body. You'll notice that the pituitary gland does some very heavy lifting. The thyroid also is doing a lot, and the adrenal glands at the head of each kidney are also going to be doing a lot as well. So hormones travel in the bloodstream and come in contact with virtually every cell on their way through the body. The target cell is going to refer to the cells within the body that are programmed with a receptor that can respond to the hormone. So the target cells are cells that can be affected by the hormone, even though the hormone is traveling and touching every tissue that we have. Target cells have receptors, and receptors are protein molecules that can recognize and bind to specific hormones. Cells without receptors are not target cells, and they're going to be unaffected by the hormone. The different mechanisms of influence that we're going to be working with here are going to depend on the chemical makeup of the hormone. The only unifying definition for hormone is chemical signal that travels through the blood. So there's a lot of different chemicals that fall into these categories. They can be broken down into two main categories, however. Those are going to be the lipid soluble, so the ones that have non-polar bonding and can go and dissolve into a fat, and the water-soluble ones, which are going to include polar molecules that are capable of dissolving into water. So lipid-soluble hormones are going to be derived from cholesterol. They're going to include different types of steroids, such as like estrogen and testosterone. And the main organs that are going to be secreting steroids are going to be the sex organs, the ovaries and the testes, as well as the adrenal organs that are at the head of the kidney, your adrenal glands. So lipid-soluble hormones, they move very easily through the plasma membrane. They bind receptors inside the target cells. And then from there, they're going to be anchoring to the name of the receptor is going to be the steroid receptor complex. And that's going to go and be floating free in the cytoplasm, or it's going to be floating free inside of the nucleus. In the nucleus, hormone receptor complexes can actually bind to the DNA in order to go and activate certain genes to synthesize specific proteins. So this is the way that the secondary sexual characteristics are going to occur. This is how they're going to get signaled to go and get started in their production. So if we look here, steroid hormone passes through the phospholipid bilayer, passes through the nuclear envelope, binds to a receptor on the way. That receptor is going to enable a certain behavior or the change in the nuclear envelope to accommodate the incoming hormone. And then that's going to go and activate certain genes on the nucleus, which is going to result in the associated tissue production or protein production. So water-soluble hormones tend to be made out of amino acids, the building blocks of proteins. They have trouble passing through the phospholipid bilayer, and these tend to be considered the first messengers. We think that these are an older form of hormone, like these evolved first. So water-soluble hormones are only able to exert their efforts indirectly. What they do is they bind to the receptors on the surface of a target cell, and then stimulate messengers on the other side of the membrane within the cell to go and start messaging the cell to go and influence the cell's behavior. So water soluble hormones take a little longer to go and induce their effects because they basically have to knock on the door, say a message, and then wait for a hormone on the other side of the phospholipid bilayer to hear that and then start carrying out its function. They have an extra layer to get through before they can fulfill their functions compared to a lipid soluble hormone. Now, one of the more common secondary messengers is going to be the cyclid adenosine monophosphate, also known as the CAMP molecule. This is a hormone that's going to bind to a receptor site on the target cell membrane, which is going to activate the conversion. All right, sorry. I wasn't going through that well. So basically, this is a common secondary messenger program or hormone. The outer layer of the cell is going to go and have a receptor that the hormone's going to go and be targeting. That's then going to send a signal through the cell membrane in order to go and start the conversion of ATP to CAMP inside of the cell. This leads to an enzyme cascade and eventually leads to the activation of proteins that have already been created within the cell. So here's that process. Step by step, we have our water soluble hormone. In this case, it's epinephrine, also known as adrenaline, that binds to a receptor. That receptor sends signals to an enzyme on the interior of the plasma membrane through the plasma membrane, starts converting ATP to CAMP. This leads to our enzyme cascade, which eventually triggers the breakdown of glycogen into glucose. It's as a message inside of the cell. So this is a breakdown of short-term storage to immediate use molecule, because this is the animal version of starch. Well, this is the same sugar that everything uses for energy. Now, in summation, so lipid-soluble hormones must be bound to proteins when they travel through plasma because they're not water-soluble. They need to be bound to something that is water-soluble. When they are bound to a protein, they can cross the plasma membrane to enter the cell. From there, they're going to bind to receptors in the cytoplasm of the nucleus, and they're going to go and stimulate the synthesis of proteins. Water-soluble hormones can freely travel through plasma, but they never enter the cell. What they do instead is they activate proteins that already exist inside of the cell by signaling different messengers that are inside of the cell to start the reaction through the cell membrane. Now, there's a significant amount of research being done on steroid hormones, the sex hormones. We are starting to think that they might have additional mechanisms of action that we're not fully understanding up to this point. And they also may be interacting with membrane receptors instead of just passing through the membrane. This research is kind of hard to conduct, though. Cell science is one of those neglected sciences because there's not a lot of money in it and it's incredibly hard to do. But there is research being conducted on this currently. So here's a video that just kind of describes that process. Let's have a look at it. Alrighty, so that's just a bit more of a detailed and verbose explanation of the processes. I find these videos pretty useful. If you want these videos with audio, by the way, you can download the presentation and then open the videos, and they do have audio files associated with them. Zoom just for some reason doesn't want to capture the actual audio files from them, so it's always quiet. Not sure why. Now, uh, going so okay, so functions and mechanisms of hormones. There are negative feedback mechanisms that do interface with different hormones. This is a pretty common limiting factor inside of most biological systems, not just for hormones. But basically, the increase the amount of stimulus, the further the inhibition of the product. So if as we add more and more of the hormones, that's going to inhibit further release of that hormone. So an example of this would be like your pancreas. So as you are getting higher and higher levels of insulin in your blood, this is going to go and mean that the insulin's no longer going to go and be reacting with the cells to go and signal them to go and absorb blood glucose. And so these levels of insulin are going to go and tell the pancreas to stop making insulin. It will not try to push it above a certain threshold. Yeah, and if there's no glucose in the blood, then that insulin isn't doing anything, and so it's going to start contributing to that total. It's not going to want to pass that total. Here's another video that's talking about the most common hormones and the systems that they come from, similar to that diagram that we discussed earlier. Oh, whoops. Sorry, folks. So, adrenaline, I was trying to pause the video. Adrenaline and adrenaline are also known as epinephrine and noepinephrine. I do not know why they changed the name arbitrarily, but they did. Right. So that's a pretty cohesive coverage of the fight or flight response. Right. Alrighty. So there are, in addition to the negative feedback loops that tend to be associated with homeostasis, a number of positive feedback loops are also utilized in the regulation of hormones. So, positive feedback loop, positive feedback mechanism. So, where the outcome of a process further feeds into the process. These are less common than negative feedback loops, quite frankly, because they do not move something towards homeostasis and they are very energy expensive to maintain. So they also tend to go and be rare for those reasons as well. Uh, a good example of this would be like oxytocin. So oxytocin is something that is induced by pressure on the uterine wall. It's a hormone induced by pressure on the uterine wall, then triggers uterine contractions. So if there's something in the uterine canal, like a child per se, and oxytocin is released, that will go and cause the uterine wall to contract against the body of the baby, helping to go and push it out. But that resistance is going to trigger further oxytocin production, stronger contractions, and that's going to continue until the obstruction is removed and there's no more stimulus telling the uterus to produce oxytocin or to contract. Typically with the birth of the child, well, there's nothing in there anymore. Here's the chemical process associated with some of that. So, all right. So we start here with the head of the baby stretches the cervix of the mother's uterus right before delivery. In response to the stretching, nerve impulses are sent to the hypothalamus. The hypothalamus signals the posterior pituitary gland to release oxytocin. The posterior pituitary releases oxytocin, which then travels through the circulatory system to the uterus. The uterus responds to oxytocin by contracting very rigorously. Uterine contractions increase the dilation of the cervix, which stimulates further release of oxytocin, which stimulates more frequent and vigorous contractions, which keeps continuing until the baby pops out. At birth, the stretching of the cervix lessens, and therefore the positive feedback loop is going to be broken because there's no more stimulus saying, hey, release more oxytocin. So, interactions between hormones, they can be antagonistic. This is when one hormone opposes the function of a different hormone. Oxytocin can be, if I recall right, oxytocin and adrenaline work inversely with each other. And they can also be synergistic, which is where one hormone is going to go and induce a response, and the other hormone is going to induce the same response, and together they're going to induce a much more extreme response. So, good example of this would be like testosterone and adrenaline. Like both of them cause induced contractions of the secondary skeletal or of the skeletal muscles, reduce response of the digestive tract, and both of them are going to go and trigger digest less, be stronger. Now, interactions between other hormones are permissive in that one hormone, in order to function at all, needs another hormone present. So, like, one is the key that opens the door, the other is the one that does the job. So the pituitary gland is the pituitary gland and the hypothalamus. We've already touched on them a little bit. But the pituitary gland is going to be located at the base of the brain, and it's going to consist of two lobes. The anterior lobe, which is going to have the circulatory connection to the hypothalamus, and the posterior lobe, which is going to have a neural connection to the hypothalamus. So interior pituitary is going to be connected to the hypothalamus, as was said on the last slide. And this is going to be controlled by releasing or inhibiting hormones from the hypothalamus. So it's also going to be used as a portal system. Basically, a portal system is when one capillary bed is interfacing with another capillary bed. Typically, if they need to exchange a very large volume of things in a small amount of time. The hypothalamus synthesizes and secretes releasing and inhibiting hormones. So a releasing hormone is going to stimulate hormonal secretion by the interior pituitary. Inhibiting hormone is going to inhibit hormonal secretion by the interior pituitary. So the hypothalamus is going to be releasing the hormones that directly control the function of the pituitary gland. And they're going to be communicating through both the portal system, which is circulatory, and an electric system that's going to go and be based off of the posterior. So here's a list that's going to go and show both those interactions as well as the specific hormonal response that's going to be associated with those organs. So the pituitary glands are going to be sitting inside of a bone cavity in the skull known as the Turkish saddle. It's one of the earliest structures that was identified in relation to the endochronological system. It was identified in the 1300s roughly. And they're going to be stimulating all of these hormones, mostly in association with reproduction. Follicle stimulating hormone is going to be essential for the standard fallopian or follicle cycle. So like the monthly reproductive cycle in women, as well as luteinizing hormone. These are going to be the ones that tell the follicle to maintain an existing pregnancy, or tell a follicle to release an egg because it failed to go and be fertilized that month. Growth hormones is going to be released. That's in part why you see secondary sexual characteristics associated with like muscle mass and height, because growth hormone is going to be in higher levels in men than women. Prolactin, which induces lactation. The adrenocorticotrophic hormone, which is going to affect the cortex of the adrenal gland and be key to the adrenal response. Thyroid stimulating hormone, which is going to go and help your thyroid go and regulate your tissue systems. Oxytocin, which induces lactation as well as smooth muscle contractions of the uterus wall. However, at the levels that they tend to be released ambiently, it is not noticeable because it's going to be much lower than the birth levels. Oxytocin is actually essential for emotional function as well as proper circulatory function, and is present in both men and women. The kidney tubules, antidiuretic hormones also going to be coming from the posterior pituitary. This is going to go and help you regulate your rate of urination. So injuries to the pituitary gland often manifest in the form of incontinence. Now, interior pituitary gland synthesis and secretes 7 main hormones. Growth hormone prolactin, thyroid stimulating hormone, and adrenocorticotropic hormone. Adrenocorticotropic. Yeah, there we are. What a word. Uh, Follicle stimulating hormone, luteinizing hormone, and melanocyte stimulating hormone. All these are going to be coming out of the interior pituitary. Uh, Two hormones from the hypothalamus are going to be regulating the synthesis and release of growth hormone. Damage to this portion of the brain also is associated with with people with dwarfism and delayed onset of puberty and things like that. So the two hormones that are going to be coming from the hypothalamus to stimulate growth hormone release are going to be the growth hormone releasing hormone, GHRH, which is going to stimulate the release of growth hormone, and the growth hormone inhibiting hormone, GHIH, which is going to inhibit the release of growth hormone. So one's going to stimulate the release, one's going to inhibit the release. The hypothalamus is not directly responsible for. Oh, I'm wrong. Sorry. The growth hormone is produced in the hypothalamus and then hormonally stimulated to be released or contained within the hypothalamus. So growth hormone stimulates the rate of cellular division, increases cellular size, and it targets all cells. However, it tends to have a disproportionate effect on bone, muscular, and cartilage tissue, in particular during puberty. So individuals that produce abnormal levels of growth hormone in childhood typically suffer from gigantism. So before the growth plates fuse in your long bones, the presence of growth hormone stimulates them to further growth. If your growth hormone disorder starts after you've already hit your full height, after your growth plates have already fused, then you end up getting a condition called acromegaly instead of gigantism. And this is when you have high levels of growth hormone as an adult, and it causes your bone density to increase and thicken, your cardiac density to increase and thicken, like your cardiac tissue, your heart walls get thicker. And it also causes the bones of your face and the cartilage of your ears to start to thicken and become deformed. It's actually a running game that a lot of biologists have. You can look at pretty much any boxer, any wrestler, any MMA fighter, any bodybuilder, and you can tell who's on what steroid, whether it's growth hormone or testosterone or what, based off of deformities to their facial features and to their hands as a byproduct of this abnormal bone growth and abnormal cartilage growth as well. Here's an example of a few people who have this is a person who has gigantism. This is a woman who she suffers from acromegaly. So this is the tallest person who's ever existed. He was about 9 feet tall. He was an American. That's about all I can remember about him. This woman has a much more interesting, more tragic story. So she had a couple kids. Her husband died, and she needed to find a way to support them. So she signed up with the circus as part of a freak show to be the ugliest woman on earth, which, I mean, quite frankly, I think she just looks like a bit of a butch lady. I don't know. I think that they were being very mean in that. But she did go and pull an incredible fortune and was able to go and fully fund her children's educations, as well as a McMansion somewhere in Wisconsin. So ultimately, I think it probably worked out for her. But as you can see, even though her proportions stay roughly standard, like she is still the same height, her hands are still the same size and ratio to her face, all that stuff, her actual bone structure is gradually thickening, and certain sexual secondary characteristics that would be associated with testosterone or masculinity are starting to emerge, like a heavier chin, widening and flattening of the nose. These are associated with high growth hormone levels in the adult phase. which is more common in men than it is in women. So typically, these tend to be more masculine traits. But yeah, a little bit of history for you. Everything's connected. End of the day, if you want to be a good biologist, you should learn your history. And if you want to be a good historian, you should learn your biology. Now, anterior lobe growth hormone disorders continued. So, pituitary dwarfism. This is when you do not produce enough growth hormone in childhood. And this can be treated in childhood if it is identified. So, this is part of why frequent checkups with a pediatrician are very important for children. A lot of these disorders can be solved very easily, but only if you catch them when the patient is still a child and pretty quick after onset. Like every second that they have this order is a second that they're not going to be growing. So that's a second lost on their max height, on their max health potential. It's best to go and catch this stuff early. This is how it looks in an adult. You notice that they tend to be a little bit more proportionate than a typical individual with dwarfism. Other forms of dwarfism are caused by other hormonal or genetic issues. This form tends to go and leave the person rather proportionate and with straighter limbs. So it leads to less secondary health issues towards the terminus of their life. The exception to this is that their torso is going and their skull may be undersized, which can lead to cognitive deficiencies, as well as certain issues associated with body cavity organ function, although the limbs tend to be healthier than in other forms of dwarfism. So anterior lobe continued. Prolactin is a hormone that's going to go and mainly be produced in females. It's produced in small amount in men and is important for duct function, especially related to your lymphatic system. But females are going to go and but in females, prolactin is primarily going to be associated with lactation. It's going to stimulate the mammary glands to produce milk. In excess of this material can go and lead to random lactation in people, but also can go and lead to scarification of the ovaries and the development of ovarian cysts. So it's something. So if somebody starts spontaneously lactating, they need to go in and get evaluated right away because it could be a sign of ovarian cysts, which both of which are being induced in this case by prolactin when the person should not have prolactin in them, or when they have too much prolactin. In males, it's involved in the production of mature sperm in the testes. It relates in large part to the maintenance of the straight, small ducts and tubes that the sperm develop inside of. However, an excessive level leads to scarification of the same tissues and cysts forming on those structures. The testicles and the ovaries are the same structure in the womb before having their traits defined by sex hormones. So they're going to go and have similar manifestations of symptoms in response to prolactin, namely development of cysts, scarification of tissue, and eventual sterility. All right. So trophic hormones are a class of hormone that influences the secretion of hormones from other glands. They're kind of a middleman hormone. These are going to include TSH, ACTH, FSH, and LH. So these are going to be luteinizing hormone, follicle stimulating hormone. I don't know ACT, and I think TSH is thyroid stimulating hormone. So let's see if I guessed right on the next page. Here we are. So thyroid stimulating hormone, TSH, is going to target the thyroid gland, stimulate the synthesis and release of thyroid hormone T3 and T4. ACTH, which stands for adrenocorticotropic hormone, are going to target the adrenal cortex and control the synthesis and secretion of glucocorticoid hormones, which are also known as the stress hormones. And this is going to include anything that's going to contribute to your fight or flight response. And after you've calmed down, the then toxic metabolites that are the byproduct of that. Stress damages your body. because your body's getting into combat mode. It doesn't care about maintaining you for a long time if it's just trying to get you through the fight, right? Follicle stimulating hormone. Uh, in males, it's going to promote the development of egg cells and the secretion of estrogen, and it's going to target the follicle or on each ovary, which is going to go and be the site of hormone production as well as the site of the egg. So follicle stimulating hormone is going to go and stimulate that follicle to keep growing, that egg to keep growing, uh, up at least until it realizes that it's no longer fertile. Now, in men, follicle stimulating hormone is going to aid in the production of sperm, and it's going to target your Sertoli cells, which are like the life support cells for your sperm cells, like the production cells. These are going to go and like keep all the tissue at the right temperature, keep them supplied with liquid and electrolytes and all that stuff. Yeah, so they don't work without follicle stimulating hormone. Luteinizing hormone in females induces the corpus luteum or the follicle to rupture if it is not fertilized. And this is going to go and start ovulation. So the follicle, also known as the corpus luteum, is going to be secreting estrogen and progesterone. Luteinizing hormone is going to go and cause that follicle to stop producing progesterone. Progesterone is the pregnancy maintenance hormone, or the pregnancy maintenance hormone. So if the follicle gets fertilized, if the egg gets fertilized, then it's going to continue producing progesterone to go and maintain the pregnancy. And it's also going to go and increase the production of estrogen to help maintain the pregnancy. In men, it's going to go and be key to the production and secretion of testosterone in the Leydig cells of the testicles. All right. Now, melanocyte stimulating hormone is going to stimulate pigment production, except it does not really have a lot of effect on humans, except during development and pregnancy. So the main thing that melanocyte stimulating hormone is going to do outside of those circumstances is it's going to go and help with regulating your libido and your hunger. It's going to encourage both of these. While the baby's in the womb, this is going to go and determine their melano pattern for the rest of their life. And this is going to go and be largely genetically determined. This is in part why skin tone can be pretty accurately traced to certain latitudes and associated with certain ethnic groups. Now, pregnant people also can be a bit more subject to the action of melanocytes. So occasionally a pregnant woman will go and start to see a darkening in the skin on the back of the neck, as well as the back of the hands. And that could mean two things. That could either mean you have diabetes, in which case you might have that occasionally happens arbitrarily to pregnant women, something that needs to be corrected, or you have too much melanocyte stimulating hormone. Either way, they both need to be checked. Now, your posterior lobe does not produce any hormones at all, but it does have the neural interface to the hypothalamus. And the neural interface to the hypothalamus is going to be producing the antidiuretic hormone and oxytocin. So antidiuretic hormone and oxytocin travel down the nerve cells. They are a form of neurosecretory cell, and they're going to be stored and released by the posterior pituitary. So even though they're not made in the posterior pituitary, they're going to go and be regulated by it. This video is going to go and talk about that process a little bit. Alrighty. So that's just a way to just to help you visualize the process a little bit, because there's a lot going on here. Now, antidiuretic hormone is also known as vasopressin. It really comes down to it's going to come down to the publication, which version they're going to use. And this is going to increase water reabsorption in the kidneys. It's going to do this by increasing vasorestriction, and in doing so, that's going to increase your blood pressure. So this is going to be a reaction of the body to drought. This is going to be how you're going to reclaim a lot of your moisture to avoid waste. Okay. What it really is doing is it is increasing the osmolality of the cells of the DCT and the collection duct. So that's just going to go and be increasing their capacity for water, usually through their interactions with salts, either by increasing or decreasing their salinity. Now, if you have a deficiency of ADH, this is going to result in a disease called diabetes insipidus. And this is just going to go and lead to excessive urine production, extreme dehydration, and it can be lethal. However, once it's been identified, it's pretty easy to correct. You can go and take ADH in a nasal spray, and after that, it's just like a daily prescription. They tend not to have too many visible symptoms after that. Now, oxytocin in females, uterine contractions, and lactation. And it's also going to go and be related to gentler emotional states. So like emotional states associated with like kindness and empathy and like soft fuzzy feelings are going to go and be associated with oxytocin production in both sexes. Oxytocin production in females is going to be stimulated by pressure on the cervix and stimulus to the nipples. In men, it can be stimulated through the nipples. Target is going to go and be the uterus, the mammary glands, and the brain. Also the smooth tubes of the testicles. Again, oxytocin is going to go and mediate healthy sperm production as well. Now, in men, it's going to facilitate sexual behavior. Oxytocin is necessary for any sort of emotional state that involves intimacy or, again, empathy. Like if you are thinking nice thoughts, it's oxytocin as part of that. You need oxytocin to go and facilitate sexual behavior and all those behaviors I just described. Help in the transportation of sperm. Stimulate sexual excitation. Like you cannot get aroused if you do not have oxytocin. And it's going to be targeting the vas deferens, which is going to be a complex of tubes inside of at the base of the testicles for moving sperm, and the brain. All right, so here, let's start here. So the infant stimulates the nerve through suckling. This sends a nerve impulse along the hypothalamus to the hypothalamus. The hypothalamus is going to signal the posterior pituitary to release OT, oxytocin. Posterior pituitary oxytocin is going to travel through the bloodstream to the mammary glands, and then that's going to in turn induce lactation. Now, just give me a second here, folks. Oops. Okay, we are about halfway through. So your thyroid is going to be a shield-shaped structure at the interior aspect of the neck. The hormones produced are going to include the thyroid hormones, which are going to be thyroid hormone, thyroid 3, and thyroid 4, and calcitonin, also, which is abbreviated as CT. So thyroid hormone is going to include thyroxine, T4, and triiodothyronine, T3. and that's going to be produced in the follicular cells. In general, that this is how we're going to go and maintain, thermoregulate, and maintain our metabolic rate in relation to thermoregulation. It's going to go and help our body maintain our blood pressure, and it's going to go and promote normal functioning of all the organ systems involved with metabolism, heat production, or blood pressure, which is going to be most of them. So this is how it works. So here's your trachea, your larynx, and then wrapped around it is going to be your thyroid gland, which is going to have these parathyroid glands anchored into the back of the structure. When you zoom in, the thyroid tissue is going to be composed of these follicular cells that are going to be wrapped around these large follicles, which are going to go and be producing the hormones, these follicular cells. So they're a historically very common disorder of the thyroid gland was called goiter, and it came from a diet deficient in iodine. So iodine's naturally present in certain types of soils. So crops from those soils and animals eaten that were grazing on those soils tend to have a decent amount of iodine in their tissues. And it's and it's present at very high levels in seafood. So if you were part of a culture from an area that did not have a lot of iodine, none of your food was going to have iodine, and you're going to go and get this disorder that led to an enlarged thyroid gland. In the modern era, most food sources that do not have iodine in them are supplemented with iodine, and the majority of salt that is sold for use in food is supplemented with iodine. This is one of the most successful nutrient supplementation campaigns that has ever been undertaken. Thyroid and goiter has almost been eliminated, even though it's one of the most common and one of the most lethal issues that people used to have. Another issue that people can go and get with is called cretinism, which it was a mean term because it was defined very early, back when, quite frankly, doctors were dicks, and so it's associated with too little thyroid hormone, and it's going to occur during fetal development or infancy, and it's going to result in a person who's going to go and have dwarfism, delayed mental and sexual development, or stagnated sexual and mental development. Like, this can be a learning disability that does not get better. Like, these people can be permanently mentally stunted. I personally think we probably should change the name. It seems a little bit mean to be calling someone with dwarfism and mental retardation a cretin, but I don't know. I'm not. I'm not a fan of this. Then we also have myxedema, and that is where you have too little thyroid hormone in adulthood, and it leads to fluid accumulation in the facial tissues. As this is occurring, the person's going to be losing alertness, their body temperature is going to be going down, and their heart rate's going to be declining. This also is going to look similar to heart failure, which is also going to manifest with similar symptoms, fluid accumulation, and then lethargy. Graves' disease is a disease associated with overproduction of thyroid hormone, and this is an autoimmune disorder. It's going to go in so it's basically it's a byproduct of antibodies mimicking the shape of thyroid stimulating hormone, and it leads to accelerated metabolism, sweating, nervousness, weight loss, protrusion of the eyes from fluid accumulation, as well as excessive hair growth. In a horse and most quadrupeds, this disease would be called Cushing's disease. The condition of fluid accumulation behind the eye is also pretty common in glaucoma, and this is going to be known as exophthalmos. The Greeks got to that one first. All right. Here's an example. This is a person who has goiter. This is a baby that has cretinism, and this is somebody who has exophthalmos. So goiter is just going to be extreme swelling of the throat, usually bilateral, but sometimes not bilateral, and best treated with iodine. Cretinism, hormone supplementation as soon as it's diagnosed, along with therapy and educational intervention in order to go make sure that the kid can integrate in a little bit better. And then exophthalmos, that really comes down to hormonal correction, and if necessary, they can drain some of the fluid from behind your eye along the tear duct. Yeah. Right. Right. Hi. I'm at in the middle of recording a lesson. Would you mind giving me a minute? Oh, okay. Yeah. Yeah. We're all good in here. Thank you much. Holly? Wait, is it Holly? Did I forget a holiday? Ah, dang it. I always miss that one. Although this one is the best food, I swear. All right. Well, thank you much. All right. So calcitonin CT is going to go and be produced by parafollicular cells, because that was in the middle of what's going to turn out to be a 2-hour video. I'm not going to spend a half hour to try to find it and edit it out. Anyway, so that's going to go in. So that's going to be produced by parafollicular cells, and it's going to stimulate. It's going to go and be released in response to high blood calcium levels. So there's a lot of different processes that are going to induce high blood calcium levels. This can be anything from muscular breakdown to bone breakdown, things like to just hormonal shock. We've already talked about a lot of the pathways that involve calcium in previous weeks, but how calcitonin is going to go and be reducing blood calcium levels, it's by lowering the level, is by indirectly promoting bone production. It's going to go and make calcium available for bone production again. It's going to inhibit the breakdown of bone, so it's going to stop the action of the osteoclast while stimulating the action of the osteoblasts that we talked about. And it's going to inhibit calcium reabsorption in the kidneys. So that's just going to go and make sure that the calcium is starting to go and be reabsorbed by the skeletal system for long-term storage. Now, the parathyroid glands, those 4 little masses at the back of the thyroid gland that we talked about, these are going to be secreting parathyroid hormone, also known as PTH, or parathormone, if you're stupid. It's parathyroid hormone. This is going to go and be stimulated by low calcium levels, and it's going to do the opposite of calcitonin. Parathyroid hormone is going to increase your blood calcium levels by inhibiting the action of the osteoclasts, stimulating the action of the osteoblasts, inhibiting bone reabsorption, inhibits and allows for breakdown of bone, which will in turn release calcium. So this is going to go increase calcium reabsorption into the kidneys, and it's also going to which is in turn going to help circulate it throughout the body, and this is also going to increase vitamin D activation. So vitamin D is going to stimulate calcium absorption in your GI tract. That is in part why vitamin D is so important. Without it, you don't absorb calcium and your bones start to break down. Now, undersecretion of parathyroid hormone can result in nervousness, muscle spasms, and general wasting, similar to the other thyroid diseases. Oversecretion leads to increased calcium release from your bone tissue, leading to degradation of the bone tissue, kidney stones, accumulation and calcification of soft tissues, and in general, decreased activity of the nervous system, because, as we talked about, calcium is very important for nervous function. So too much is much worse than too little for this particular hormone. So these are going to go and be, so these are the systems that are going to be regulating your blood calcium level. They're going to go and be working with and against each other at all times in order to keep this balanced. Now, your adrenal glands are going to be superior to your kidneys, and they're going to be composed of 2 regions. The adrenal cortex, which is going to be the outer region, and those are going to go in, and those are going to secrete the gonatocorticoids, the glucocorticoids, and the mineralocorticoids. The adrenal medulla, the inner region, is going to secrete, by contrast, epinephrine and no epinephrine, or adrenaline, no adrenaline, depending on, again, what school you went to. So your gonatocorticoids, these are going to be the androgens and estrogen. So that's going to be secreted by the adrenal cortex, specifically from a region called the zona reticularis, and it's going to occur in both males and females. And these are going to be your estrogen, your testosterone, all the sex hormones. Your mineral corticoids are going to help maintain your mineral homeostasis and water balance, and they're going to go and be mainly metabolized in the zona glomerulosa. Aldosterone is going to be an example of a mineral corticoid. That's going to go and target principally the cells of the kidney to increase the reabsorption of sodium ions and increase the secretion of potassium ions. So that's going to go and that's going to be key to the function of the sodium potassium pump, and this is how we're going to be mediating the action and the efficacy of the sodium potassium pump throughout different tissues and regions of the body. Now, glucocorticoids are going to affect glucose homeostasis, and they're going to be mainly created in the zona fasciculata. These act in large part on the liver, and they're going to promote the conversion of fat and protein into glucose, increase the mobilization of fat and amino acids, and inhibit the inflammatory response. So all of these are going to be their metabolites. So like they're going to be associated with the stress response. I was actually part of a study when I was an undergrad where we measured glucocorticoid metabolites in the fecal matter and blood samples of cattle. And in doing so, we were able to create a stress index of how stressed out the cows were at different times of day in different parts of the dairy. Now, Addison's disease is a byproduct of an undersecretion of two of these glucocorticoids, these being cortisol and aldosterone. This is a pretty gnarly autoimmune disorder. It leads to destruction of the adrenal cortex, and it can be caused by inadequate secretion of ACT. I can't remember what that one stands for. I'm awful at acronyms. Now, this is going to lead to a darkening and bronzing of the skin due to hyperactivity of the melanocytes, extreme weight loss, fatigue, extreme electrolyte imbalance, poor appetite, and pretty extreme responses to stress. We're talking like they lose 5 pounds because they got into an argument, that sort of thing. Like it leads to like the stress management pathways are completely destroyed. This was something that Kennedy was afflicted with. At the time, a lot of people actually accused him of using bronzer, but no, he just had this disorder. Interestingly enough, we were at this point unable to treat this disorder, so this most likely would have killed Kennedy within the next 5 to 6 years. Cushing syndrome is a byproduct of a prolonged. So Cushing's one of the ones that I mentioned earlier, and it is a byproduct of prolonged exposure to high levels of cortisol, which could be induced by many things. It could be induced by a tumor. It could be induced by extreme long-term stress. It could be induced by disorders of the adrenal cortex or anterior pituitary that aren't tumor-based, but are just based off of hyperexpression. Yeah, it's pretty gnarly. So this leads to a redistribution of the body fat, fluid accumulation in the face, and it's associated with increased appetite and weight gain. Or, you know what, guys? I think I gave you a wrong definition of Cushing's earlier on. There's an inverse syndrome that afflicts the thyroid to Cushing's. I can't remember the name of it, but it basically is doing the opposite. I imagine it's going to be the next few slides. So this is someone with Cushing syndrome before and after receiving treatment, and also before and after getting a haircut and getting their hair bleached and also getting their makeup did. Either way, you can see the person lost a lot of weight. They lost some of that fluid accumulation and discoloration. And in general, they have a better health prognosis long term. Now, the adrenal medulla is going to produce epinephrine and norepinephrine, both used in the fight or flight response. These are sympathetic responses, so they're going to be working they're going to be they're going to go and be working with the sympathetic system instead of the non-sympathetic system. So these are going to be not controlled by your active thoughts. It's going to go and be controlled by the instinctual and subconscious thoughts, same as your smooth muscles versus your skeletal muscles. This is going to be a short-term stress response. It can't be maintained long-term. The body just starts to go and become immune to the adrenaline. Long-term stress leads to hypothalamus stimulation of the anterior pituitary, and then leads to the release of ACT. Once released, it signals the adrenal cortex to produce cortisol and aldosterone. So here are those pathways. So here we have our hypothalamus, and this person has received a stress response. Maybe someone just slapped them, or they just got their tax return and it was half what they expected. It could be anything. So short-term stress, the hypothalamus communicates with the adrenal medulla via nervous signals through the spinal cord. This then leads to short-term stress response of an increased heart rate, respiratory rate, and blood glucose level, as the adrenal medulla is going to go and be releasing epinephrine and norepinephrine into the system, triggering the fight or flight response. Now, during long-term stress, the hypothalamus communicates with the anterior pituitary via hormonal signals. The anterior pituitary signal then sends ACT to the adrenal cortex. So, remember, the anterior pituitary does not produce its own hormones. It's just going to go and be mediating and distributing the hormones that are going to be produced by the hypothalamus and then stored here. Those are then going to travel to the adrenal cortex and trigger the release of mineral corticoids and glucocorticoids, which are going to be reabsorbed by the kidneys, increase your blood pressure and blood volume, and start to go and break down your proteins and fats and reduce your inflammation response, and start to go and throw your liver into overdrive, all of which is very stressful on your bodily systems and can reduce longevity. Now, the pancreas is an auxiliary organ. It's going to be located posterior and inferior to the stomach, and it's going to have specialized endocrine cells that are going to be arranged into clusters instead of just all doing one task. So these clusters are going to be called pancreatic islets, or the islets of Langerhans, named after the scientist who discovered them. And they're going to produce glucagon and insulin, which are two hormones that are direct antagonists of each other and have opposite functions. So glucagon is going to go in response to low blood glucose, target the liver and body fat to have them release glucose into the blood. Well, in the liver, it's going to go and produce glycogen conversion to glucose as well. And it's going to start converting lactic acid and amino acids into glucose, burning proteins in order to do so. Insulin, by contrast, is going to go and be released in response to high blood glucose. It's going to target every cell in the body, but in particular the muscular cells, the liver cells, and the fat cells. So this is going to lead in a decrease of blood glucose levels by stimulating the transport of glucose into the cells for storage for later. It's also going to inhibit glycogen breakdown to glucose and prevent the conversion of amino acids and fatty acids to glucose in the liver. So it is just the inverse of every process that's being done by glucagon is done by insulin instead. So here are some pancreatic exocrine cells. This is part of the auxiliary function with the digestive tract. And here are some pancreatic islet cells with endocrine tissue that's going to be making hormones to be released into the rest of the body. So this goes into the digestive tract. This goes into the rest of the body. Very different functions. And this is kind of showing that regulation between these two hormones and how they maintain normal blood glucose levels. Now, metabolic disorders, diabetes mellitus. So, this is a group of metabolic disorders that are going to be characterized by abnormally high levels of glucose in the blood. And it's going to go and be associated with a problem with either insulin production or the function of their insulin or the sensitivity of their receptors to insulin. So there are two major types, and that's going to go and characterize 95% of cases. That is type 1 diabetes and type 2 diabetes. There are two minor types of diabetes, namely gestational diabetes, as well as pretty much any sort of disorder to the pancreas that can go in, that can damage the tissue is going to go and probably going to induce a form of diabetes if extreme enough. It's a major cause of death and disability. Insurance is awful about covering diabetes things, but diabetes is very, very lethal. So you'll go and hear in the news all the time about people who couldn't afford their insulin and ended up dying, or people who or people who their insurance refused coverage, so they lost both their feet. Like, it is, if you need any evidence that insurance is awful and working and people shouldn't be reliant on insurance for health, as a society, then the way that they just let hundreds of diabetics die for a chemical that is easy, that can be produced for like a couple bucks like a jar, and we've been doing it for 100 years. And the original patent owner said they never wanted anyone to be charged for this and made it public domain before the insulin industry swept it and made it and did all. I don't know. The point is, uh, if you don't take care or care about your fellow man, what's the fucking point of you, really? So now moving past that, pancreas secretes insulin, responds to high levels of blood glucose. Insulin promotes glucose movement into target cells, increases the number of glucose transport proteins, also known as GLUTs, inside of those target cells to facilitate the movement of insulin or of glucose into the cell. So high blood glucose occurs when there's not enough insulin or target cells do not respond adequately to insulin. So the way that we tend to typically treat this is by giving the person insulin supplementation whenever their blood sugars are too high. So here's how that process kind of works. Here's the pancreas just tucked up alongside the stomach. And this is how it's going to go and be reacting to different situations. So in type 1 diabetes, the pancreas does not produce insulin, really. Like, it produces little insulin or no insulin. And this tends to be genetic. It's very common in children. Like, we tend to identify this very early in people's lives. Now, type 2 diabetes is insulin insensitivity. So this is where the body cells fail to respond to the insulin that's being produced. This can be a byproduct of a lot of different things. Poor diet can induce this one. Injury to the pancreas, injury to the stomach, chronic stress. There are also certain genetic things that will go and make you significantly more prone to getting type 2 diabetes than not. It's one of those things where one of the worst things I ever heard from a biology teacher was they were saying, it's like, well, type 1's sad because, it's genetic, but type 2, they deserve it. Well, that biology teacher was an asshole. 90% of the time, people can't help it if they go and get this disease. Even if it is associated with obesity, there's a lot of things that cause obesity. Like, I've worked with patients who were eating like less than 1,000 calories a day and were still obese because of hormonal issues. So you never quite know what's going on in someone's story. Saying that someone deserves a disease because fat people sometimes get it from eating too much is pretty fucking awful. And again, what's the point of that person? They're not contributing to the betterment of humanity. They're just a dick. If you learn anything in this class, because I know this is a hard class and a lot of this material can get very frustrating, just try to be kind to your fellow man. Always have empathy and know that everyone deserves a good meal, safe place to sleep, medical care, and clean water. It's a really low bar. If you're willing to give it to an animal, you should be willing to give it to a person. Now, type 1 diabetes mellitus. So this is an autoimmune disorder. Immune system attacks the beta cells of the pancreas. The beta cells are the ones that produce the insulin. This leads to destruction of beta cells. Insulin must be delivered by injection or pump, and this is about 5 to 10% of all diagnosed diabetes cases. Type 2 diabetes is associated with overeating, obesity, and inactivity, as well as physical injury to the pancreas, as well as chemical injury to the pancreas. Like type 2 diabetes is the type you tend to get if you have a toxin that targets the pancreas. A lot of pesticides do that as kind of an unfortunate byproduct. And it tends to be characterized by insulin resistance to exterior tissues. So this also can be induced through exposure to different types of chemicals and radioactive elements, but it is most commonly a byproduct of chronic high blood sugar from diet and low caloric requirement or sub intake and caloric requirement. I want to emphasize again, this diagnosis is not a moral diagnosis. This diagnosis just tells you a different mechanism to go and treat your patient through. Like it's not any of our jobs to judge our patients. We're here to deliver care. Now, symptoms and complications. So, extreme thirst, frequent urination, hunger, extreme weight loss, fatigues, and full body sores are pretty common byproducts of type 1 diabetes. Type 2 diabetes is going to go and have all the same symptoms, but it might have them in varying levels of severity because type 2 diabetes, different types of tissues can have different types of resistance. So while they might be manifesting skin sores and dehydration because their kidneys and their skin is a bit more sensitive to the symptoms of diabetes than like their muscular tissue, and they might not have any weight loss or hunger or because it's all based off of type 2 is a disease that slowly develops over a long amount of time. Type 1 is spontaneous. A lot of these symptoms simply won't be noticed because the patient might assume that's normal. Now, a couple of the complications of diabetes, hyperglycemia, so high blood sugar, that's going to go and lead to a huge amount of issues. Sugar crystals will form in your blood and start lacerating different capillaries in your eyes, your fingertips, and your feet, leading to mass tissue damage and then mass tissue death. This leads to blindness, requires amputation of the fingers, of the toes, of the feet and hands. In addition to that, urinary tract infections. There's a lot of capillary beds down there, and they'll get infections for similar reasons. In addition to the fact that sugar will start to accumulate in the urine, which makes it makes it significantly more attractive for bacterial blooms, also increasing the amount of urinary tract infections. Then the opposite condition, hypoglycemia, from low blood glucose. This is most common in people who accidentally take too much insulin in response while they're early into their diabetes, or if they have like a particularly bad episode and they're not thinking clearly. That's going to lead to extreme drop in blood sugar, possible diabetic coma, and possible death. That one is a very immediate danger compared to hyperglycemia, which is a long-term danger. Another complication that can emerge is diabetic ketoacidosis, which is a life-threatening chemical disbalance most common in type 1 diabetes. Basically, because you no longer are getting your energy from sugar. Your body is having to break down lipids and proteins in order to go and produce this energy instead. When you break down proteins for energy, it creates a waste product called a ketone. A ketone is going to be closely related to all the volatile fatty acids, And a ketone's going to go and one of the most common ones is acetone. Acetone's used as a paint stripper and used to go and take nail polish off of fingers. When you are mainly getting your calories from protein, the acetone's going to build up in your blood, and it's actually going to be, you're going to be able to smell it on people's breath. This is in part why the keto diet is so dangerous, because you are inducing this to try to go and trigger weight loss, but having paint thinner in your blood tends not to be very good for your long-term health. And this leads to a lot of kidney damage, muscular damage, and psychiatric damage. The people under long-term ketoacidosis undergo brain damage. So, don't do the keto diet. It's a fad and it's stupid and it's dangerous. Now, long-term complications, high blood glucose damaging blood vessels. So basically, diabetes is going to form tiny crystals of sugar in your blood. It's going to start lacerating the hell out of all your capillary beds. And all these tissues that are being afflicted all have capillary beds, which is what's going to go and be getting damaged. In addition to that, it induces high blood pressure, which is also going to be further aggravated by the obesity often associated with type 2 diabetes. Infections of the skin and gums are also pretty common due to this accumulation of sugars, and depression as well. Depression in type 2 diabetic patients is incredibly high, in part because of the stuff that I've already mentioned. People are really dicks about it. Like, people treat them like they have failed a moral prerogative by getting sick, and that is not the duty of a healer. And on top of it, it's just incredibly painful. All the capillary beds in the body are filling with sugar crystals, and this is oftentimes after a lifetime of pretty hard living. And it's very common in old people as well, and similar issues. I would say depression here is just one of those things that it's mentioned more as a byproduct of people being shitty about fat people in the US rather than an actual direct symptom of the disease. So best treatment is very nutrient dense foods, but that are low in fat and calories. I favor you want to avoid brassicas in the initial part of the treatment because the sulfides can be a bit rough on the gut. But in general, you want to go and maximize your fiber intake, coarse leafy greens. You want to go and make sure that they're eating dark leafy greens, especially. Eventually transition to more of a brassica heavy diet just because it's more nutrient dense. But at the end of the day, if you're trying to treat type 2, you could often correct it by normalizing their insulin levels for a while and getting rid of the excess body fat, which can in turn make them more sensitive to insulin. This is not a guarantee. Oftentimes you cannot recover once you've hit a clinical level. And there are also, if you were given type 2 diabetes by a secondary injury, like exposure to a toxic compound or a genetic propensity, it might not be able to be corrected simply through diet and exercise. They might require drug intervention or surgical intervention. And again, you should not have a judgment call on these patients. Like, everyone has their own things they're dealing with, and the difference with them is they actually tried to get help, right? So empathy is one of those things that we don't teach. I think we should. And it's one of those things that I think is going to carry you guys in your careers way better than anything else we talk about. So, exercise and a diet with high fiber, high nutrient loading, but low fat calorie, and honestly protein levels as well. In addition, you're also going to be wanting to treat with a hemoglobin, which is going to go and help improve their blood function and go and help reduce the effects of those sugar crystals lacerating tissue. And often there will be a variety of diabetic drugs that they're going to be given. Insulin as needed. Omnizec, some of the newer ones, work through inhibiting appetite and inhibiting your cell's ability to go and or mitigating your cell's ability to absorb sugars. Like a lot of the new diet drugs work directly with this, and a lot of them were developed uh, as diabetes treatments before they were even thought of to be used as a weight loss drug. Yeah. Now, type 1 diabetes cannot be prevented. It is genetic. It is the result of permanent pancreatic damage. Their islets are destroyed, and their immune system is going to destroy it again if we even magically regenerated the tissue. The best that we can do for these folks is to get them on an insulin pump so that they don't have to think about it throughout most of the day. Make sure they have insulin readily and cheaply available, and make sure that the healthcare infrastructure can go and provide those things without it becoming a disproportionate burden on the patient. Type 2 prognosis. Again, this can be induced by injury. It can be induced by chemistry. It can be induced by exposure to pesticides or nerve agents. Like, for instance, you see this a lot in people coming out of Syria because they were getting hit with illegal nerve agents that were inducing this condition. It was destroying their pancreases. But in general, for type 2, specifically tissue sensitivity, uh, it can be it can be treated with weight loss, exercise, and extremely strict diets, along with careful administration of certain classes of drugs and hormones, insulin. Now, it is important to note again that this also might not be able to be corrected, but there is a much better prognosis for correcting this type of disorder than there is for correcting type 1. Another type of disorder that women often develop is gestational diabetes. Uh, about 7% of all pregnancies in the US induce basically the baby is producing a lot of different hormones, and that's going to go and make the mother's cells more resistant to insulin. And it's going to go, and typically they'll just put the mother on a slight supplement of insulin until the baby is born, at which case it corrects itself, since the baby was the direct cause of the symptom. Yeah. Now, this can go and lead to preeclampsia, which is a life-threatening disease. Leads to high blood pressure and fluid retention throughout the tissues of the body. And it also leads to the babies being larger than normal, which is going to lead to difficult deliveries, especially if the individual has already been severely weakened by over the course of this disease. It's very, very dangerous, which is why, this is why you should be talking to your prenatal care. It's very important. Like prenatal vitamins and all that stuff. Like, you really need to be on it if you get pregnant. And honestly, like, if you're a guy, you should probably be on vitamins before you start trying for a baby. If you're trying for a baby, it just leads to a better long-term health prognosis for both the kid and the mother. It's the right thing to do. Now, the excessive growth in the prenatal period, high level is due to high levels of glucose in the maternal blood, and it is going to pass to the fetus via the placenta. However, insulin from the mother cannot pass to the fetus, so this can lead to damage to the baby's tissues. Around 3 months of gestation, the fetal pancreas begins to produce its own insulin, and it's going to be responding to the high glucose levels around the body. And very often that's going to go and lead to excessive growth of the baby. Birth weight's going to be well over 9 pounds. And also potentially the baby having type 2 diabetes, because it's going to have cellular insensitivity to insulin as a byproduct of this particular disorder. The thymus lies superior to the heart, secretes hormones, and promotes the maturation of T lymphocytes, which are a type of immune cell. These are going to include thymopoietin and thymosin. So your pineal gland is going to be located at the center of the brain. It's going to produce melatonin, and it's going to go and produce more levels at night than during the day. So melatonin's the nighttime or the sleepy hormone. So you're going to receive inputs from the visual pathway, and light inhibits the secretion of melatonin. So humans are typically considered a tropical species because we're from sub-Saharan Africa originally. But if you look at where we are from in sub-Saharan Africa, we still were subject to seasons, which means, and recent research has shown that humans are what is known as a short day breeder, which means that we will have our offspring. We prefer to have our mating season during the shorter half of the year, so like during the winter season as a byproduct. And it has been noted that melatonin has a secondary byproduct of making you produce extra sex hormones. So if you take a very large melatonin supplementation, like before bed or whatever, you're going to go and start noticing really high testosterone and estrogen levels. And you typically are going to start noticing it when you start to go and lose your hair, get acne, get joint pain, and get erectile dysfunction if you're a guy. So, melatonin is one of those ones that you do want to be careful with, the same way that you would go and be treating like testosterone. Small little doses every once in a while are fine. Don't do that with testosterone. Actually, treat it differently than testosterone. Small doses of melatonin sporadically are fine, but if you take them regularly in large amounts, you are going to start messing with your reproductive system. Now, too much melatonin can result in seasonal affective disorder because you're basically tricking your brain into thinking it's the deepest depth of winter. And if you put in a lot of melatonin, you're tricking your brain into thinking that you're in the dark 24/7, which can make you sad. That's not a good thing. You don't want that. Now, local signaling molecules, these are hormones that signal to immediate adjacent cells, and they can actually act very quickly. So neurotransmitters are going to go in be a subcategory of this sort of hormone. This also includes growth factors, which are signals to cells that tell them to start growing, developing, multiplying, all the things associated with tissue regeneration. Oh, something kind of interesting. So one of the more common hormones is actually a very simple molecule, nitric oxide or NO. This is going to stimulate vascular dilation. It's going to be the key ingredient in Viagra because that is the main mechanism. Nitric oxide is the main mechanism by which the male erection is controlled. It causes vasodilation in that tissue and allows blood to go and pump through. It also is going to go and be key to cardiac function. The original Viagra was actually developed as a cardiac treatment for arrhythmia, and it was effective for arrhythmia, which is why it's still prescribed to a lot of people today, including females, for treatment of that condition. Nitric oxide also was historically used in dental offices. However, it's not a very effective painkiller. It's kind of dangerous. You really don't want to be pumping people full of a neurotransmitter. So that practice has ceased since that point. So, and I forgot to mention, nitric oxide, there is some preliminary research saying that it might be important for peristaltic movements. So like those pulsing movements, like what moves food down your throat. However, the publications related to this have been kind of sparse, and I'm not a huge fan of a lot of their conclusions that they drew. So I'm going to be waiting to go and see what the next publication says on it before I have any opinions. Now, local signaling molecules continued. Prostaglandins. These are lipid molecules that are continuously released by the plasma membranes, and there are 16 total. So prostaglandins have incredibly diverse effects on all the systems throughout the body. They influence the reproductive system, your inflammation response, your ability to clot your blood, your body temperature. Prostaglandins are very versatile and honestly just cover too many things to go over today. Now, Within this framework, you should now be able to explain the role of hormones as chemical messengers and give examples of hormone regulation. You should be able to list the effects of the 6 interior pituitary hormones and the 2 posterior pituitary hormones. You should be able to explain the regulation of blood calcium by calcitonin and parathyroid hormone. You should be able to name and describe the effects of the hormone produced by the adrenal gland. You should be able to compare the effects of the 2 pancreatic hormones, glucagon and insulin, on the regulation of glucose blood levels. You should be able to describe the effect of the thymus gland on the health of the immune system. You should be able to relate the production of melatonin to seasonal affective disorder and name the glands that are involved there. You should be able to define prostaglandins and describe their rough mechanism of action as compared with endocrine hormones. So the mechanism of action for prostaglandins, again, it's going to be just released by the plasma membranes, and it's going to affect all the tissues that are immediately around it instead of circulating like a normal hormone. Alrighty. That was a long one, folks. Thank you for sticking with me through that. The recording is going to be posted online. And again, any sort of feedback is always welcome in a course like this. We're going to be having our assessments out in a few weeks. I am going to be making that a graded assignment just to go and encourage participation. And that's the point when you can go and give me all the feedback that you think is necessary. This class is a community effort. I take all the feedback I get from you guys to heart, and I try to go and apply it to our work. And all you can do is make the class a better place for the next set of students to come in, or for yourselves, as we still have a decent amount of course left, and I'll still be putting out work for us. With that, y'all have a great day. Stay safe and enjoy your weekend.